a group of disorders in which they are this group are different types of glaucomas. They are connected by the main basic symptoms: changes of the optic nerve head and visual field loss. About the intraocular pressure. Increased intraocular pressure is the main pathogenetic mechanism of the damage of the optic nerve head and associated changes of the visual field. But as we know, the normal parameters of the intraocular pressure, like any other parameters, normal, as we said, normal parameters of the human body, they are a result of the examination of the general population. And the most frequent results are the normal results. But as we know, in any population, there exist a lot of persons, a group of persons whose individual normal results, in our case intraocular pressure, is out of the limit of the normal, statistically normal intraocular pressure. So there may be such situation in real clinical practice when we can see the normal intraocular pressure, I mean statistically, technically normal intraocular pressure, but we can see symptoms of the glaucoma. It means that this person, this particular person, has individual norma less than in general population. And intraocular pressure, for example, 20 millimeters of mercury, which is normal. Statistically, for this particular person is too much, and we can see development of glaucoma. On the other hand, we can see another situation, the so-called ophthalmic hypertension, when we can see persons and we examine them for many years, they have increased intraocular pressure, for example, 24, 25 millimeters of mercury, but they have no signs of glaucoma. And we check their visual functions, their optic nerve head, their visual field, and we can see no glaucomatous changes of the eye. And such persons, they have a very high level of individual norma of intraocular pressure. So even such a high intraocular pressure can't start the process of glaucoma development. So glaucoma nowadays, it's just a risk factor for glaucoma development and progression, but not a clinical sign. Only two main clinical signs we can name: optic nerve head disorders and changes of the visual field, loss of visual field. And on the basis of two these disorders, we can put the diagnosis of glaucoma. Pathophysiology of glaucoma revolves around the aqueous humor dynamics. The aqueous humor is a clear, watery fluid filling the anterior and posterior chambers of the eye. I remind you that anterior chamber is a space between the posterior surface of the cornea and anterior surface of the iris and crystal lens, and a small space between the behind the iris and between the iris, posterior surface of the iris and anterior surface of the vitreous body. This is the so-called posterior chamber. They are connected each with one with another by the pupil, hole in the center, aperture in the center of the iris. Ciliary processes of the ciliary body is the seat of aqueous production. Their position is in the posterior chamber. There exist three mechanisms of production: diffusion, ultrafiltration, and secretion, the so-called active transport. They play a part in its production at different levels. Aqueous humor flows from the posterior chamber into the anterior chamber all the time, and the process of its production is also continue all the time. Um, through the pupil against slight physiologic resistance. And then from the anterior chamber, the aqueous is drained out by two uh, routes, by trabecular outflow and the so-called uvea-scleral outflow, two main ways of aqueous humor outflow from the eye. So all the time we can see the process of, on the other hand, process of the production, on the other hand, process of the outflow of the aqueous humor. And as you understand, if there will be any changes in the balance between two these um, processes, we will see the increased or decreased intraocular pressure. Trabecular outflow is the main outlet for aqueous from the anterior chamber. About 90% of the total aqueous is drained out via this route. Trabecular meshwork is situated in the angle of the anterior chamber. Next to the trabecular meshwork is present the canal of Schlemm. It's the name of the famous scientists who described the anatomy of the angle of the anterior chamber. In the substance of the sclera, aqueous humor is drained from the anterior chamber to the canal of Schlemm through the trabecular meshwork and then to the collector channels through the intrascleral aqueous vessels into the episcleral veins and through the veins of the orbit out of the eyeball. So this is the process and the way of the aqueous humor outflow. Some endogenous factors do influence the aqueous formation. Passive mechanisms of aqueous formation are depend on the level of blood pressure in the ciliary capillaries, the plasma osmotic pressure, and the level of the intraocular pressure. So if we can see the balance in all these mechanisms, our intraocular pressure is normal. Patients' intraocular pressures are normal. If there will be disbalance in one or several steps of this way, we'll see the changes of the intraocular pressure. The intraocular pressure refers to the pressure extended by intraocular contents on the coats of the eyeball. The normal IOP varies between 10 and 21 millimeters of mercury. If we use Goldman tonometry, the gold standard in most of the countries of the world. If we use the NEUMA tonometry, which is now very popular, and you can find in NEUMA tonometers, which use the air under the pressure, puff tonometers in all the offices of the ophthalmologist. In our country, we use Maklakov tonometer and the normal intraocular pressure. There exists a bit difference from 18 to 21 millimeters of mercury. But for you, the most important normal intraocular pressure level of intraocular pressure is from 10 to 21 millimeters of mercury. In your countries, you will use, I think, Goldman tonometers or something like that. The following factors determine the level of IOP. Rate of aqueous secretion, resistance encountered in the outflow channels, and level of episcleral venous pressure. Fluctuation of intraocular pressure, it was in the previous slide, occur with the time of the day, with the heartbeat, blood pressure level, and even respiration. The pattern of diurnal curves of IOP varies in the normal eye with a tendency to higher intraocular pressure in the morning and lower in the afternoon and evening. In case of some disorders, in case of glaucoma, for example, you can see changes of this diurnal curve, and sometimes you can see peaks of IOP, diurnal peaks, not in the morning, but in the evening or even at night. But as you understand, it's very difficult to check intraocular pressure, not in the office hours, but in the evening or especially at night. Only the special ophthalmological centers it's possible, but it's also really difficult. Normal eyes have a smaller diurnal fluctuation, less than 5 millimeters of mercury. The anglocomatous eyes, in which the fluctuation may be even 10 millimeters of mercury or more. What methods of examination of the eye appendages, and different visual functions should we use for the patients with glaucoma or glaucoma suspect? Visual acuity examination, as for any other patients, ophthalmic patients. Slit lamp examination. You know, it's a binocular microscope by which we can see enlarged image of the anterior surface of the eye appendages, and we can find risk factors for glaucoma formation, dystrophic changes rather frequently associated with glaucoma development, and several other additional signs which can help us to put the correct diagnosis. Intraocular pressure measurement. The method of its checking is called tonometry. Tonus means pressure, so tonometry means measure. So tonometry, Greek word, means examination of the intraocular pressure. Then ophthalmoscopy. As you remember, one of the main signs of glaucoma is changes of the optic nerve. So ophthalmoscopy, examination of the fundus of the eye, it's one of the ways how to check the condition of the optic nerve head. Then visual field examination, second important sign of glaucoma is loss of visual field. So by this examination, the so-called perimetry, we can determine whether exist any changes of the visual field or not. Gonioscopy. Gonios, Greek word, means angle. So gonioscopy, it's a technique of biomicroscopic examination of the angle of the anterior chamber. Normally, the angle of the anterior chamber is covered on the periphery of the cornea and periphery of the iris. We can't see the structures of the angle of the anterior chamber without special lenses. But we use these lenses. We put them on the surface of the eye after the installation of anesthetic eye drops, and we can check the angle and its structures to understand is it open angle glaucoma or angle closure glaucoma or several other specific types of glaucoma and so on. Additional methods like tonography, non-invasive technique for determining the facility of aqueous outflow, or special provocative tests are popular in the glaucoma clinics. Tonometry. There exist two basic types of tonometers, of equipment for the examination of IOP. Indentation, for example, short tonometer, applanation tonometers, which are the gold standard Goldmann tonometry in Europe, in America, Maklakov tonometry in Russia, and several surrounded countries. A rough estimate of IOP can be made by digital tonometry. And during our practical classes, we try to train you how to palpate the eyeball to understand the intraocular pressure of your patient. Of course, we understand it's really difficult to determine the exact result, how many millimeters by palpation. By palpation, you can only say, is it normal or increased or decreased? And there exist several degrees of increased intraocular pressure during the palpation. We use this method for the diagnosis before the start of the thorough examination of the patient with modern computer equipment. About the provocative test, there exist several types of tests. What does mean provocative test? We use this test, for example, water drinking test or Prescoll test or several others to change the patient's intraocular pressure. For example, the water drinking test, based on the use of the water which we advise patient to drink, about 1 liter. And then the IOP is measured every 15 minutes for 1-2 hours. Normally, in normal persons, non-glucomatous persons, we can see increasing of intraocular pressure because we by drinking water, we increase the rate of aqueous humor production. But normally, this difference in IOP before and after the provocative test is not more than 5 millimeters of mercury, usually 2-3 millimeters, not more. But in glaucoma patients, we can see a high amplitude of IOP, more than 5, sometimes 7-8 millimeters of mercury. So these provocative tests we use in the doubtful situations, and these tests can help us to prove the presence or absence of glaucoma. The same situation with the several drugs which we also use. They have a different influence on the intraocular pressure. We measure IOP before and after the test, before and after instillation or drinking the drug, and then make a conclusion based on the amplitude of IOP in this particular person. There exist 3 main types of glaucoma: congenital, primary, and secondary. So the main signs are raised IOP in most of the persons more than normal, the statistically normal, 21 millimeters of mercury. But at the very beginning of our today's lecture, I explained you that there exist persons with the normal, statistically normal IOP, but presence of glaucoma. And on the other hand, there exists a group of persons with increased IOP, but no other signs of glaucoma, the so-called ophthalmic hypertension. And 2 other signs, glaucomatous optic nerve damage and glaucomatous visual field defects, we can see both of them in all the glaucoma patients. Let's discuss in details the changes of the optic nerve disc and changes of the visual field. So, optic nerve head or optic nerve disc, it's a place of connection of all the nerve fibers in the retina and the place of the formation of the optic nerve. In the center of the optic nerve head or optic nerve disc, there exists a special cup. It's a pale depression which is not occupied by neural disc tissue. Glaucoma causes a progressive loss of the retinal nerve fibers. So the glaucoma changes of the optic nerve are pallar area or disc, and in advanced stages, optic disc appears white and deeply excavated. We can see enlargement of these glaucomatous, of this optic cup with the development of the optic atrophy. Marked cupping excavation may even approach the disc margin. Visual field defects include bearing of blind spot, different types of scotomas. I hope you remember from the previous semester what this means scotoma. It's an isolated defect of the visual field, which is not connected with the visual field borders. Patient may sense this scotoma in form of spot, dot, gray or black in front of his eyes. Sometimes our patient has negative scotoma. It means we can determine it during the perimetry, but patient has no complaints on this scotoma. He has no such complaints. Contraction of the visual field. Here you see how does it look like the surrounded world of the patient, and in the next picture it will be even more bright. How does it look like the world if you are glaucoma patients of different stages? So the first picture, photo number 1, this is the normal visual field. You see no constriction, white visual field borders. The second one, it's an initial stages of glaucoma, when we see a constriction in all the meridians, peripheral changes. In this stage, patients usually has no complaints, and especially if it's a unilateral glaucoma, usually no problem with the visual field. Visual acuity in this stage is normal, so patient has no complaints. Because of that, unfortunately, we get our glaucoma patients, a large group of our glaucoma patients in advanced stages of glaucoma. And it's very important to understand that as soon as we have to start our treatment as soon as possible. We can't recover the damaged optic changes, the optic nerve fibers. We can just stop the progress. So if you manage to find the glaucoma in early stage, you have a chance to keep the visual functions of the patients for a long period of time without loss of quality of life. But if your patient comes to you in advanced stage, we can only stop the progress, but we can't recover the lost visual field, and so we can help such a patient to improve his visual functions. The third picture, you see in the nasal part of the visual field, you see a sort of, we name it nasal step. Then we can see that in fourth, fifth, and especially sixth photos, patient has only the rest of his visual field, and all the surrounded world is dark for such a person. Of course, if you see such patients like in photos number 5 and 6, it's a disabled persons with the decreased visual acuity, with the only peripheral visual field. They have no central vision at all, and it's a real risk for them even to cross the road, because they have no central vision and very small island of the rest of the periphery, even if their visual acuity is not so damaged like in other disorders. Glaucoma is one of the main causes of the irreversible blindness in all the world. And one more photo where you can compare the optic nerve head changes and associated visual field loss. 4 stages of glaucoma. The first column, it's a scheme, it's a picture of the optic nerve disc. The second column, it's a photo of the real patients. And the third column is the scheme of the visual field. Here you see in the first photo, you see the cup of the optic nerve disc. This is depression in the center. It's rather small, and you can see only enlarged blind spot, small scotoma in the center, without usually any complaints. Here you see enlargement of the central part of the optic cup, and you see the problem with the visual field in the nasal part. Very large glaucomatous cup, and you see that more than half of the visual field is absent. And the final, the terminal stage, absolute glaucoma, you see no normal color of the optic nerve disc on the periphery, so grayish, whitish in the center due to the progressive loss of the nerve fibers, and you see only small islands of the visual field through which the patient, of course, can't see clear and can't watch TV or drive the car or something like that. His quality of life is very poor in this stage, and this person is, of course, disabled. As I said before, there exist 3 types of glaucoma. Congenital is one of the types. The congenital glaucoma is also not an isolated pathology, it's also a group of disorders in which abnormal high intraocular pressure results due to developmental anomalies of the angle of the anterior chamber, obstructing the drainage of aqueous humor. About half of cases of congenital glaucoma manifest within first year of newborn's life. We name this situation infantile glaucoma. And in some cases, the onset may be delayed up to 3 or to 15, 16 years of life, juvenile glaucoma. Sometimes it is associated with other congenital anomalies. Clinical features. Photophobia. Patient can't look at the bright light, small patients. Of course, such you understand that it's in humans, they have no complaints. They can't say that. We can see only the crying baby, but we can see photophobia if you put the bright light on the surface of the eye. The small child try to close their eyelids or to turn the head to decrease this irritation. Blepharospasm, spasm of the eyelids, like a reflex on the bright light. Lacrimation. Often they occur together. Corneal signs. Corneal, we can see corneal edema. Let's have a look at this cornea. It's not a very huge, severe pathology, but you see the changes and the partial opacity of the cornea. Corneal edema is, and on one of the next photos, you'll see it. You see it's opaque due to the edema, and it's frequently the first sign which arouses suspicion. And also we can see corneal enlargement. You see in this small child, it's look very large, the cornea and the iris, which it looks like when we open the small patient palpebral fissure, it's only cornea, no sclera, only somewhere on the periphery. Of course, this condition is abnormal. Normal infant cornea measures about 10 millimeters in diameter. A diameter more than 13 millimeters confirm enlargement. We have special equipment for the measurement of the diameter of cornea, but if you have no, you can use the simple ruler-meter. Just put it on the patient nose and try to measure the diameter. If you see such a situation, this is enlarged cornea, and sometimes we name it ophthalmos, bull-like eyes, where the cornea is very large. Sclera becomes thin and appears blue due to underlying UL tissue. Optic disc may show variable cupping and atrophy if it's possible to check, because, for example, in this photo, we can see the totally opaque corneas, and through these corneas, we can't see any underlying structures. We can't examine the fundus of the eye. IOP is raised, of course. The eyeball enlarged, and so the term ophthalmos is used. As a result, due to retention of aqueous humor, the term hydrophthalmos, hydros means, water, has also been suggested. Treatment of such a condition. It is primarily surgical. Unfortunately, even the most effective anti-glaucoma drugs can't help, because we can see in such persons the obstruction of the angle of the anterior chamber, the pathway of aqueous humor outflow, by the mesenchymal tissue. Normally, all of us before the birth has such a mesenchymal tissue in the angle of the anterior chamber, but before the birth, there exists a spontaneous resorption of this tissue as a result of any congenital anomalies. There will be no resorption of this tissue in such a person, and no possibility of aqueous humor to outflow. So the task for the surgeon is to remove the mesenchymal tissue from the angle of the anterior chamber to open the aqueous humor outflow, to open the trabecular meshwork. Procedures are called goniotomy and trabeculotomy. With the help of special equipment, special needles, with the help of special lenses, we managed to decrease the intraocular pressure. And if the period of such edema and ophthalmos was not so long, we managed in some cases the total recovery of the visual functions of the normal condition of the eyeball, normal parameters, anatomical parameters of the eyeball. In advanced stage, we should also perform the surgery to stop the progress, but in most of cases, advanced stages, the signs and the loss of visual functions are irreversible. We can just stop the progress. Usually we manage to keep the visual functions, but the degree of visual functions depends on the situation, on the stage, and on the level of the basic level of the increased intraocular pressure, and so on and so forth. So as soon as possible, it's necessary to perform this surgery. Drugs we usually use only for the period before the surgery. Primary glaucoma, second type of glaucomas. There exist two types of primary glaucoma: open angle and angle closure. Sometimes we can see a combination of two types of glaucoma in the same person. So what's about the primary open-angle glaucoma? Uh, in this type of glaucoma, the aqueous humor has unimpeded access to the trabecular meshwork in the angle of the anterior chamber. But there is abnormally high resistance to the fluid flow through the trabecular meshwork and Schlemm channel and angle tissues. Rise in IOP occurs due to decrease in the aqueous outflow facility caused by thickening and sclerosis of the trabecule. Predisposing and risk factors are heredity, the approximate risk of getting disease in siblings is about 10%. It's rather high. Age, it's one of the most frequent eye disorders, age-related eye disorders. Um, the risk increases with increasing age, and usually we can see onset of glaucoma after 40. The average age of primary diagnosis is about 60, 62 years. The primary open-angle glaucoma is more commonly in patients with high myopia, with diabetes mellitus, which are also risk factors for this pathology. So myopic patients, patients with diabetes, we should check the intraocular pressure, the optic nerve disc, and the visual field more frequently than patients without such symptoms to try to put the early diagnosis of glaucoma if it's possible. What about the clinical features? Primary open-angle glaucoma is a silent process, unfortunately. Usually there are no symptoms. Only about 10-15% of patients have such symptoms as a mild headache or eye ache, occasional colored halos due to transient corneal epithelial edema. A halo, it looks like a circle of different colors when you look at the source of light. This phenomenon, optic phenomena, is the result of the edema of cornea due to high intraocular pressure. But not in all the persons with glaucoma, primary open glaucoma, the intraocular pressure is so high to cause the corneal edema. In most of them, there is no edema, so no halos, no headaches, no eye ache, and only progress in the visual field loss, in development of the optic nerve atrophy, and this is the result why they come to us in advanced stages of glaucoma. Gradual loss of peripheral vision occurs. Loss of central vision is usually the last to occur. And you understand that the main complaint of most of the patients is the problem with the central vision. If they see rather poor for far, they come to the ophthalmologist. If their vision is rather high, they have no suspicion, they have no problems, and of course, they usually do not visit us. Ocular examination, including slit lamp biomicroscopy, may reveal dystrophic changes of the anterior segment. Changes of the iris usually. Gonioscopy, you remember it's an examination of the angle of the anterior chamber, reveals open angle, as you understand from the name of this type of glaucoma. The main symptoms is raised intraocular pressure, but not in all the patient, as we said several times before. In the initial stages, the IOP may be not raised permanently, but there exists an exaggeration of the normal diurnal variation. So we should examine IOP 2 times a day during several days. If, for example, you have an office hours uh, from 9 a.m. to 5 p.m., ask the patient to come one day at 9, second day at, for example, 4 p.m., and several days try to change the time. And maybe you'll find the time of the peak IOP in the evening or in midday, but not in the morning. It's sometimes it's very important, and it will help you to prove the diagnosis of glaucoma. Glaucomatous changes in the optic disc may be seen in patients with primary open-angle glaucoma. They're typically progressive, asymmetric, and present a variety of characteristic clinical patterns. Visual field defects usually run parallel to the changes at the optic nerve disc, and thus will continue to progress if IOP is not controlled. Remember this table in one of the previous slides where we compare the changes of the optic nerve disc and visual field in different stages of glaucoma. Okay, let's have a small break for about 10 minutes, and then we'll continue with the other types of glaucoma. Okay, I hope you are ready to continue. Let's start with the next portion of slides. To finalize with open glaucoma, um, we have to discuss the differential diagnosis uh, with cataract, another age-related pathology of the eye. Patient with primary open-angle glaucoma have red reflex during distant direct ophthalmoscopy. Ophthalmoscopy reveals glaucomatous changes of the optic nerve disc. IOP is raised and visual field defects may be seen. In case of cataract, you see decreased reflex or absence of red reflex. And if it's possible to check the fundus of the eye, you'll find no changes from the optic nerve disc. Classification of open-angle glaucoma, there exist 4 stages. In the first or initial stage, there is no changes of the optic disc and peripheral visual field. We can put this diagnosis only on the base of the specific, very high technological equipment, for example, optical coherence tomography, or special computer, visual field computer analysis. In the second stage, we can see constriction of the visual field borders, more than 5 degrees, even in 1 or more meridians, and central paracentral scotomas. In the third stage, advanced stage, we can see marked constriction of visual field. In 1 or more meridians, we can see that the visual field border is less than 15 degrees from the point of fixation of the central point. And in fourth stage, there is no vision, or only light perception with RON light projection, or even zero total blindness. Visual functions in glaucoma may be stabilized or non-stabilized, and in this case we can see progress, and we need to change something in our line of management, to use another types of drugs, or to use glaucoma surgery. So we should be more aggressive in this case, in case of non-stabilized glaucoma. Primary angle closure glaucoma. It's a type of primary glaucoma in which usually sudden rise in IOP occurs due to blockage to the aqueous outflow by closure of a narrower angle of the anterior chamber. The peripheral iris tissue covers the trabecular meshwork, preventing access of the aqueous humor to the trabecular meshwork. So there exists a block, mechanical block of the anterior chamber angle. Trabecular may be normal. In case of primary open glaucoma, you remember there exists sclerosis, constriction of the spaces in trabecula. In this case, trabecula may be normal, but there exists an obstruction of the trabecula by the iris root. Predisposing factors: anatomical, eyes in which iris length diaphragm is placed anteriorly, then eyes with narrow angle of the anterior chamber, which may be due to small eyeball, relatively large size of the lens, and anterior position of the ciliary body. First of all, due to the effect of precipitating factors, dim illumination, emotional stress, use of mydriatics, there occurs mid-dilatation of the pupil, which increases the amount of position between iris and anteriorly placed lens, with a considerable pressure resulting in a relative pupil block. The aqueous collects in the posterior chamber, because there is no outflow from the anterior to the posterior chamber due to the pupillary block, and pushes the peripheral iris anteriorly, resulting in a positional angle closure due to iridocorneal contact. Eventually, there occurs rise in IOP, which is transient to begin with. Clinical features. The type of glaucoma usually begins with acute or subacute attack. Patient complains of headache and eye, blurring of vision, colored gallows around the light due to corneal edema. Frequently, it may be associated with nausea, vomiting, and prostration. Sometimes the pain may radiate to the heart or stomach area. You may compare with the previous type of glaucoma, primary open angle, that you see the difference, the great difference. A lot of complaints, very severe complaints, associated changes of the systemic conditions, and so on. Examination shows congestion of conjunctival and ciliary vessels. Cornea becomes edematous and insensitive. Here you see the partial opaque of cornea, and we can see clearly the underlying iris. Anterior chamber is very shallow. Angle of anterior chamber is completely closed, as seen on gonioscopy. Iris may be discolored. Pupil is dilated, semi-dilated, vertically oval and fixed. Optic disc is edematous if possible to see it through the edematous cornea. Optic disc is also edematous, and it looks like mild hyperemia. IOP is markedly elevated, usually between 40 and 70 millimeters of mercury. So in 3-4 times more than in normal person. Slowly, the positional angle closure is converted into synechial angle closure due to formation of peripheral synechias, adhesions between the iris and crystal lens, and an attack of rise in IOP may last rather long. Subacute attacks is characterized by the same symptoms, but in less degree. IOP is raised about 35-45 millimeters of mercury. Subacute attack less dangerous than acute. Diagnosis, history of the disease, results of examination, and provocative tests, but very, very carefully, because you can cause the acute attack by these tests. So you should be very careful in this type of glaucoma. Differential diagnosis. Acute attack of primary open angle glaucoma, angle closure glaucoma, sometimes needs differentiation from other causes of inflamed red eye. First of all, from acute iridocyclitis. And here you see this table. You can find it in most of the books, textbooks in ophthalmology. You see the features, like onset, like presence of colored halos, type of characteristics of pain, vision, type of congestion, problem with corneal sensitivity, anterior chamber depth, characteristics of pupil, and intraocular pressure. And you may compare the acute attack of glaucoma and acute iridocyclitis. So, as I said before, you can find this table in all the textbooks devoted to the primary angle closure glaucoma. And with the help of this table, you can rather easily differentiate between these acute disorders. Secondary glaucomas. Secondary glaucoma is a group of disorders in which rise of intraocular pressure is associated with some primary ocular or systemic diseases. Therefore, clinical features comprise that of primary disease and that due to effects of raised intraocular pressure. All types of secondary glaucomas may be grouped as follow: uveal or post-inflammatory glaucoma, then lens-induced or phacogenic glaucoma. Phacos, Greek word, means crystal lens. Vascular glaucoma, traumatic glaucoma, glaucoma associated with intraocular tumors, the so-called neoplastic glaucoma, and several other additional but rather seldom types of glaucoma. Uveal, post-inflammatory secondary glaucoma, is the result of trabecular clogging by inflammatory cells, exudates, pupillary block due to adhesion between the posterior surface of the iris and anterior surface of the lens, the so-called synechias, angle closure without pupil block due to organization of the inflammatory debris in the angle of the anterior chamber. Diagnosis, history, and examination with the history of uveitis, previous inflammation, and these signs which may help us to put the correct diagnosis. Treatment of all the types of secondary glaucoma has two directions. Treatment of the glaucoma according to the general rules of glaucoma treatment of as any other types of glaucoma treatment, and additionally treatment of the main etiological factor, in this case inflammatory or post-inflammatory changes. Phacogenic or lens-induced glaucoma. In these cases, intraocular pressure is raised secondary to some disorders of the crystalline lens. It includes following subtypes: phacomorphic glaucoma due to ulceration in morphology of the lens, swollen cataractose, anterior subluxation, and dislocation of the lens. Then phacolytic or lens protein glaucoma. In this type, trabecular meshwork is clogged by the lens proteins and macrophages. Leakage of the lens proteins occurs through an intact capsule of the crystalline lens in the fourth stage of the so-called hypermature stage of cataract, senile cataract. There are two types of vascular glaucoma exist: post-thrombotic, as the result of central retinal vein occlusion due to formation of neovascular membrane involving the angle of the anterior chamber, and phleber hypertensive. Phleber, Greek word, means vein. Hypertension is clear, increased pressure in the ocular and orbital veins as a result of raised pressure in the system of anterior ciliary or varicose veins. The main causes of this type of glaucoma are malignant exophthalmos and tumors of the orbit, which cause the compression of the veins, decrease in the outflow facility, and cause the increased pressure in these veins, and then development of the vascular glaucoma. Traumatic glaucoma, very interesting type of glaucoma. Secondary glaucoma may complicate perforative injuries, blunt traumas, which we discussed previous lecture. Traumatic glaucoma may develop by one or more of the following mechanisms. Maybe angle recession due to disruption of trabecular meshwork, followed by fibrosis, adherent leucoma, and peripheral anterior synechia formation. It may be lens-induced glaucoma due to swollen or dislocated crystalline lens. It may be due to intraocular hemorrhage. It may be inflammatory post-traumatic glaucoma due to post-traumatic cardiomyopathy. So traumatic glaucoma involve all the possible types of glaucoma, maybe except neoplastic. It may be the result of ocular surgery as a complication of cataract extraction or keratoplasty. And neoplastic glaucoma, it's clear. The glaucoma develops in cases when intraocular tumors block the drainage system. Different types of benign or malignant tumors block the drainage system, the area of trabecular vesicule, compress the episcleral veins, and so on and so forth. So, what are the basic principles of glaucoma treatment? There exist three main directions, three main branches of treatment: medical, laser, and surgical treatment. Medical treatment. There exist several groups of drugs which we use to decrease intraocular pressure. We use them in form of eye drops, of course. The most effective group of drugs nowadays is prostaglandin and Nalox. The second is beta blockers, the most frequently used anti-glaucoma drugs for many, many years, for 3 or even 4 decades before the appearance of prostaglandin and Nalox. No, timolol, the most frequent and the famous example of this group of drugs. They decrease the intraocular pressure by decreasing of aqueous humor production. Prostaglandin and Nalox increase the outflow. Among the other groups of drugs, we can name carbonic anhydrase inhibitors, sympathomimetics, and in some cases, especially for angle closure glaucoma, we can use miotics like pilocarpine. How to treat acute attack of primary angle closure glaucoma? Here you see the scheme, which is the most popular in all the world. Pilocarpine, 1%, miotics, should be administered initially 4 times during the first hour, 2 times during the second, and then 1 time each next hour. In form of instillation, it's a topical treatment. Beta blockers or sympathomimetics, prostaglandin and Nalox also should be administered to lower the pressure further. Carboanhydrate inhibitors we can use not only in form of drops, but also in form of for systemic treatment, for example, in form of tablets. Acetazolamide, the example of this drug. Here you see the doses of these drugs should be given to lower intraocular pressure if it's very high, then below 50 and 60 millimeters of mercury. If there is no effect after 12 hours of medical treatment, surgical treatment should be performed. Laser treatment is one of the steps of treatment of patient with primary open angle glaucoma in form of trabeculoplasty, laser trabeculoplasty, and several other types of laser surgery may be performed, and it's maybe especially selective laser trabeculoplasty may be a good alternative to the medical treatment. But of course, the most effective treatment is a surgical treatment. In case of primary open angle glaucoma, we use peripheral iridectomy. If there exists a pupillary block, we perform the peripheral iridectomy. We make a hole in the peripheral iris to recover the outflow from the aqueous humor from the anterior chamber into the posterior chamber. And by such a way, we decrease the intraocular pressure and we decrease the degree of the block of the anterior chamber angle by the root of iris. Then for congenital anomalies congenital glaucoma, as you remember, we use goniotomy and trabeculotomy to remove the mesenchymal tissue, uh, abnormal mesenchymal tissue in the angle of the anterior chamber. For primary open-angle glaucoma, we use filtration surgery. The golden standard for glaucoma surgery is trabeculectomy. We create, by this surgery, we create a new way for aqueous humor outflow instead of the problem associated with the trabecular meshwork, native trabecular meshwork of the patient. We create a new way of aqueous humor outflow. And uh, for them, as I said before, as a method of alternative method for to medical treatment, we can use laser trabeculoplasty by the application of discrete laser burns to the trabeculum to open the trabecula for the normal physiological outflow of the aqueous humor. In most of the country, if you check the guidelines in glaucoma, you'll find the same mechanism, the same line of management of our patients. Usually we start with the monotherapy with medicines, usually with prostaglandin analogs, if we're talking about the primary open-angle glaucoma, of course. Then, if monotherapy is not effective, we add one more drug, for example, beta blockers. Fixed combination are very popular in ophthalmology. We have a fixed combination when in one bottle you have two drugs, so this decrease the amount, the frequency of instillations, make the patient's quality of life better. So fixed combinations, of course, they have more advantages compared with the isolated use of these drugs, separate use of these drugs. If fixed combination use of two groups of drugs is not so effective, we advise the glaucoma surgery for this patient, or we can use additional laser and then glaucoma surgery. Of course, if your patient can't agree with the surgery, there exists such a group of patients who do not want to use this surgery. We can continue to prescribe the new groups of drugs, the third, the fourth, but unfortunately, as we see in our practice, in several years or decades, all these possible combinations will become ineffective. And only surgery will help such patients. But even surgery, and even now, it's not a final stage of treatment, because in 2, 3, sometimes 5, 7, maximum 10 years after the surgery, we can see the closing of this new way of the aqueous humor outflow as a result of the fibrosis, adhesion, mild inflammation in the area of the operation, and we can see decompensation of the intraocular pressure. Then we should start this cycle of management again. We can continue with, again, start with the medicines, or sometimes we can, if there exists indication, we can use even a reoperation in very early post-operative period after the first surgery. It depends on the patient. As I said before, unfortunately, in spite of our effort in all the world, glaucoma is still one of the main causes of irreversible blindness in most of the countries of the world. And we hope that in future we'll get such drugs or surgery or other technologies which will help us to, first of all, to detect glaucoma in early stage, to form the risk groups for glaucoma development in early period of our patients' life, and for effective treatment of glaucoma, and even maybe for the recovery of the visual functions, even in advanced stage of glaucoma. So we hope so, but our experience of last 2 years show us that, unfortunately, we're too far from these results. Okay, that's all for today. If you have any questions, let's discuss them. Any questions? Any ideas? Any suggestions for the future? No? Okay. Thank you for your attention. I wish you good luck. I wish you good weekend, and see you next time. That's all for today. Goodbye.
До свидания.
До свидания.
До свидания.
Thank